to welcome everyone to the Dean's Research Seminar for this day, Thursday the 15th of June. We have 3 presentations by 4 wonderful people today, so it's a jam-packed session. So we might kick off with our acknowledgement to country. Thanks, Loretta.
Okay, thanks. Sarah, did you want to start my slides, please?
Yes, no problem.
So thanks so much, Anna. I'd like to acknowledge that today's meeting is being held on the campuses located on the country of the Darug, Eora, Dharawal, also referred to as Tharawal, Wiradjuri peoples, and is being held across their lands. And because some of us are working from home, I know it's also being held on other lands. I acknowledge the rich culture, history and knowledge of the Aboriginal people and the importance and values of including this knowledge in our endeavours. I'd like to acknowledge their ancestors who have been traditional owners of their country for thousands of years and pay my respect to elders past, present and emerging, and to Aboriginal and Torres Strait Islander people that are here with us today. Their lands have never been ceded.
Thanks so much, Loretta. So welcome again, everybody. Loretta is actually going to kick us off with her presentation today. So Dr. Loretta Luck is an Associate Professor and is the Director of the Centre for Nursing and Midwifery Research, a conjoint position between the School of Nursing and Midwifery here at Western and the Nepean Blue Mountains Local Health District. Loretta supports and mentors nurse clinicians to undertake research that leads to an evidence-based change in practice, enhances patient outcomes and supports a positive workplace culture. Loretta's research focuses on the problem of violence and aggression towards nurses, exploring innovative strategies to support nurses to manage this challenge in the workplace. Her areas of research also include nursing workforce issues and nursing education. Violence towards nurses in the hospital setting is endemic worldwide, including in Australia. The physical and emotional consequences and psychosocial sequelae of violence reported by nurses include clinical depression, disturbed social and physical well-being, post-traumatic stress disorder, and increased substance abuse. Innovative solutions need to be found to manage violence towards nurses. One successful solution in the mental health context is the Safe Wards model. Today, Loretta will present on the Safe Wards strategies in 2 general nursing wards using an action research methodology. And she'll also present some of the findings from the pre-implementation and post-implementation focus groups. Thanks so much, Loretta, and welcome.
Thank you so much. And thank you everyone for joining us today. As I said, as Anna said, like violence towards nurses is an unacceptable problem nationally and internationally. So today I'd like to share with you our experience of implementing 2 Safe Wards interventions into 2 general hospital wards. Importantly, I'd like to tell you of the action research process we undertook, show you how the nurses modified the resources so they're appropriate for their context, and present some of the findings from the pre and post implementation focus groups. Next slide. Thank you, Sarah. So as Anna said, what we know is that nurses are frequently exposed to aggression and violence, and this is supported nationally and internationally in the literature. And a cross-sectional study in 2020 by Jacqueline Pitch found that nearly half of the respondents had experienced violence in the preceding week to completing the survey, and 79% had experienced violence in the previous 6 months. It's as with my the bio I gave Anna, violence towards nurses from patients and their visitors has been widely reported to have negative impacts on work performance, productivity, satisfaction, retention, and increases the rate of leave as a consequence of injury, stress, and compensation leave. It also contributes to the intention to leave nursing. And the physical and emotional consequences and psychosocial sequelae of violence reported by nurses includes clinical depression, disturbed social and physical well-being, post-traumatic stress disorder, and increased substance abuse. What we know is that the ED and mental health specialties have very high levels of violence and aggression. However, many of the patients that go to ED then need to be hospitalised for their medical or surgical needs. And upon arriving in the general hospital, in the general wards, their violence doesn't abate. So while there's a lot of work done in violence in ED and mental health settings, there's actually a lack of evidence about initiatives that address conflict and violence in general hospital wards. So we sought to find some way to decrease the episodes of violence and try and increase the safety for nurses. Thanks, Sarah. So Safe Woods, Sarah?
Sorry, Loretta, it's not progressing for some reason.
Oh, no.
That's okay. I'll just keep trying.
You keep trying and I'll keep
Yeah.
talking. Okay.
Right one. Yep.
Okay. So this is Safe Woods, and it's a nurse-led interventional model that was developed by Professor Len Bowers in the United Kingdom. And it was to address the factors of conflict and containment in mental health wards. And it describes this reciprocal relationship between conflict and containment and the domains in which they occur. And they also talk about potential flashpoints that trigger each incident. They developed these 10, and I know it's really hard to tell, probably harder to read, and I won't read them out, but they're there. They developed these 10 nurse-led interventions to mitigate flashpoints and therefore reduce violence and containment and improving the safety of staff and consumers in mental health units. In 2014, the Safe Wards initiative was trialled across mental health units in 7 self-selected health services in Victoria. The successful outcomes of this trial, which covers 18 sites, found a significant reduction in physical and verbal aggression, as reported by Fletcher, and that the staff were positive about their involvement in Safe Wards initiative, and they felt that it made their workplace safer and reduced the use of seclusion. So I guess I thought, I wonder if we could take these mental health strategies and embed them or use them in general hospital wards, and how we could do that and what that might mean. So the aim, next slide, please. So the aim was really to trying to introduce these Safe Wards interventions into general hospital wards. We'd had some previous success in a pilot in a surgical ward, but we wanted to extend our study. And the important aim of the study was to empower nurses and change nursing practice. So our objectives: to modify the Safe Wards interventions to enable them to be used in the general ward, to provide nurses with new skills to avert and respond to episodes of conflict and violence, and then obviously to evaluate the implementations of Safe Wards. So we use an action research methodology, and action research is an emancipatory research design which acknowledges that participants are actively engaged in all aspects of change to make improvements in social practice in a particular setting. It's predicated on the premise that only the participants in a social setting can understand the way practices are conducted. There's shared language used by participants which has meaning to their practice, and that the participants can develop contextually relevant actions. So it enables researchers to address real-life practical problems through this cycle of planning, implementing and assessing. And this actually aligns with the Safe Wards approach of think, plan, do. So I focus on practical activities with the goal to affect change and empower nurses, and therefore in turn improve patient care. So we wanted to have a collaborative relationship with the nurses to affect change and obviously, as I said, affect patient care. We wanted to support them to implement and assess the effectiveness of the interventions in their ward. And we wanted to help the nurses to develop new skills and confidence dealing with patients and their families' violence. We were outsiders to the ward, so we needed a lot of time to establish relationships and trust. So we had frequent contact with the nurses. And again, and rather than identifying which of these 10 interventions we wanted to introduce, we took all the 10 interventions to the nurses, and then over 27 weeks and a lot of in-services, the nurses identified which strategies they wanted to would best fit their workplace and their context. So it was an iterative process, going to the ward, providing education on the interventions, having conversations, modifying the resources, which was really important, and taking them back to the ward and having more conversations. And as I said, after taking the resources to the nurses, they made changes to the resources, and we take those changes back and we change the resources, and when we'd go back to the wards and have more conversations and change the resources. It's because we wanted them to engage as co-researchers. We also actually found that some people actually wanted to take the lead in developing and implementing the interventions. So what they selected, and both wards selected this, they selected clear and mutual expectations, talk down tips and soft words. And as I said, it was written for the mental health specialty, so we needed to do a lot of work on the constructs and language because they were specific to mental health, and we wanted to work with them to modify it to suit their workplace and the patients they cared for. As they worked through the interventions, they found that clear mutual expectations was difficult to modify to suit them, so they didn't implement this intervention. With the software resources, they chose the original resources and thought they were highly relevant to their ward. It was the talk down tips they worked most on. And they took this original resource from the mental health perspective and modified the language and changed the layout. So Sarah, if you can just kind of press through. This is the original. This is what one of the wards, how one of the wards changed the resources for their context. And this is one more. And this is how another ward changed the resource for their context. So as you can see, this actually kind of empowered the nurses and gave them ownership of the resources and gave them ownership of the interventions. And it also means that by doing this, these actually became very relevant for their ward and their context. So if I can kind of move on to the research end, what we know from the literature about research around violence towards nurses, it's usually undertaken using cross-sectional self-reported retrospective surveys. We actually chose to use focus groups to collect data. Now, the advantage of focus groups is the capacity to generate discussion around shared experiences, feelings and attitudes, and to engage the co-researchers in reflection, which obviously is aligned with action research. So by sharing and listening to other nurses' experience, it validates concept for nurses, it identifies collective perspectives, and it can trigger ideas for participants. Our focus groups took about 20 to 30 minutes, and they were usually during the afternoon in-service time in the ward tutorial rooms. We did use semi-structured interview questions for the focus groups because we wanted to find out if the nurses' experience of violence and the skills to respond and avert to violence had changed pre and post intervention. How am I going for time, Anna? Oh, I can't hear you.
You're going okay, maybe.
I'm going okay, awesome. Thank you.
5 minutes.
Oh, okay. Well, I'm not going okay. Okay, so the aim of the pre-intervention focus groups really was to find out what nurses were doing, what were they doing to predict, prevent and respond to violence. We wanted to know about some typical situations that led to violence and then the strategies they were using when they were managing it. In the post-implementation focus groups, we wanted to explore the impact of the Safe Wards project and discover if our Safe Wards changed the way nurses averted and de-escalated violence. And the focus groups were digitally audio recorded and transcribed verbatim, and we analysed the data using Braun and Clark's thematic analysis. Next slide, please. So over the course, these are the demographics of our participants, but over the course of that 27 weeks, the researcher assistant and 2 of the team members attended the wards on 62 occasions. There were 44 visits to the wards for meetings, working on resources and the posters. There were 6 education sessions on having difficult conversations and the talk down methods. So if we can go to the next slide, now to the findings. I think the first finding, it feels like a battlefield, I think probably doesn't actually surprise anyone as they shared they raised similar concerns. They had similar experiences about violence towards them. So they described being racially abused, verbally abused, physically abused, multiple occurrences of swearing, yelling, name calling from patients and visitors, lots of accounts of physical violence that were just overwhelming, being attacked, hit, kicked, and having patients actually pull monitors off walls and throw them to them. So I guess what we'd expect to hear about violence in the nursing context, although horrible, I think. The second, this space is hectic, is really when they talked about the precursors or flashpoints to violence, and sometimes they acknowledged that included poor communication, delays in the response to treatment, what happened during COVID-19 and the visiting restrictions, unrealistic patient or visitor expectations, and patients' altered cognitions. And they added that because the place was so hectic, it was sometimes not possible to have time to explain everything to the patient or family. The aftermath really reflects what I talked about earlier, the personal and professional ramifications as a consequence of this frequent exposure to violence and aggression. Most of the nurses reported being shaken and scared by the events, and some even questioned why they should continue to work in a hostile profession and did express an intent to leave. And there was a shared acknowledgement that the repetitive exposure to violence affected them outside of their work and impacted on their home and family lives. Thank you. For the next one. Post the implementation, we found that the two interventions were really well received and the nurses felt like they'd improved their skills. Several of the participants expressed confidence in dealing with difficult situations, and one participant actually described it as a game changer. The post-intervention focus groups also provided us with insight into how Safe Wards interventions can be implemented into wards. And these are the three themes that arose. Importantly, they thought after working through the Safe Wards, they felt they could prevent situations from escalating and were better equipped and more confident with de-escalation techniques when needed. And importantly, the participants' narrative gave details about how they were better able to recognise signs of potential violence and how they found the interventions useful in de-escalating a potential aggressive situation. They said it gave them a framework to guide their management of difficult situations, with several participants describing how the prompts gave them alternative strategies to apply. The empathy and self-reflection theme highlights how their ability to empathise with their clients, their patients, after the implementation of Safe Wards. They described being more insightful about the reasoning behind patient or visitor aggression and trying to understand what was happening to better address their needs. So stories around empathy were really strong in the focus group data. And as nurses, they described themselves as caring and compassionate, and that Safe Wards reminded them of their expert ability to be empathic. Moving forward, they made several suggestions about how this could be improved. They suggested that there should be debriefing and how that would give them an opportunity to assist them in managing the personal repercussions of violence. And other people just said that debriefing would be really helpful so they can vent and support each other and provide feedback to each other. So while we didn't stop all violence, there's some violence, there are just some not very nice people really. And while we couldn't stop it, the nurses did say they felt that after the implementation of Safe Ward, they were more confident to manage difficult situations and had some new effective skills to manage conflict, violence and aggression. From a methodological point of view, as I said, what we did was we actually found qualitative data from general nurses, which isn't in the literature. What tends to be in the literature is a lot of work from ED and mental health and a lot of retrospective surveys. So this really contributes to understanding the experience of violence towards med-surg nurses. A limitation of what we did is we really didn't get a chance to get the flashpoints to write the vignettes and the scenarios so they could practice using the strategies, like role play the strategies and practice them. And I'm also always conscious of when we do this work that we often don't see the night duty staff. So, and that context and that where violence happens could well be different during the night duty. So I hope that I haven't gone too far over 15 minutes, and thanks so much for your time today. Oh, just one last thing, just to acknowledge the Education and Training Service at Nepean Blue Mountains Local Health District were really supportive of this, and that I had some money from the Rosemary Bryant Foundation that paid for the research assistant. So thanks so much, Anna.
Oh, Loretta, what a fantastic study and making a wonderful contribution. Thank you. Is it okay with everyone, just due to time, if we hold questions over to the end of the session for everyone's presentations? Is that okay? All right, so we might move on to our next presenter, who is Dr. Virginia Stutz. And Virginia is an associate professor and, as you know, is working with Nepean Blue Mountains as well, and School of Nursing and Midwifery Virginia is presenting today on midwives' perceptions of the support received in Australian new graduate programs. And the aim of this study was to provide baseline knowledge about the value of midwifery graduate programs in Australia and to explore the perceptions and experiences of employed midwives about how they support new graduate midwives in transition to practice programs. So welcome, Virginia, and thank you very much.
Thanks, Anna. So today I'm going to be presenting this study. Can everyone see my screen?
Yeah.
Right. Just doesn't seem to be progressing. I might just start it again.
Mine started doing that, Virginia, and then it came okay.
Okay, let me just try it. Okay, so this is a project that I am leading, and it was identified as a research priority as part of the Trans-Tasman Midwifery Education Consortium. So I'd like to acknowledge all my colleagues for this study that we're doing. Okay, so the aim of the study is to provide some baseline knowledge about the value of midwifery graduate programs in Australia, and also to explore the perceptions and experiences of employed midwives about how they support new graduate midwives in transition to practice programs. The other part of this project, we are also recruiting midwifery graduates about what their thoughts are about graduate programs. And so we're recruiting them as a student, and then at 6 months and at 12 months. And we're still recruiting those new graduates. And today I'm not presenting that part of the study. It's only just the midwives. So I'm just going to give you a snapshot of some of our quantitative and qualitative results. So we recruited between December 20 to May 2022. And we just recruited via our own Facebook contacts. And we also recruited via the Australian College of Midwives Facebook page. And then we also, from those midwives, they're also able to tell other midwives about this study. So that was snowball sampling. We had 165 midwives that answered the survey, and they were working in all models of care and settings in all states and territories of Australia. And they were practicing from anywhere from 1 to 46 years. So we developed a 51-item survey, and how we did that, we looked at literature, and that's how we developed each of the questions, except for the demographic parts, of course. And we assessed the reliability on the 35 scaled items. And for a new tool, it's usually acceptable to get a reliability of 0.7, but ours was 0.9, so we were really happy with that. So today I'm just going to be presenting some quant results initially, and then some textual results that midwives actually wrote. So from this slide, you can see that the majority felt that they were able to support new graduates to work autonomously. If we asked if their service offered appropriate clinical experience to support the learning midwifery knowledge. So 52 responded not able to, and out of these, 11 midwives didn't offer any support programs for new grads. So the majority of midwives thought that it was important for new grads to have a mentor or preceptor. And having the resources to support new graduates, 15% said never or almost never, 50% said sometimes, and a third said almost always or always. We also just did some association. So there was a positive relationship between midwives reporting that their service offered a midwifery graduate program that created a sense of belonging to the organisation, and their midwifery program valuing new midwifery graduates' clinical opinions. And there was a significant correlation between the service providing opportunities for new midwifery graduates to practice self-care strategies. So, for example, taking breaks, clinical supervision, and also managers and other key stakeholders providing initial and ongoing support to new midwifery graduates by providing release for education sessions or supernumerary time. Inadequate staffing impacted the ability to support new midwifery graduates, was negatively associated with having sufficient resources to support new midwifery grads. and there was a positive relationship between the midwifery graduate program valuing new midwifery graduates, clinical opinions rather, and new midwifery graduates during the first year of practice being encouraged to voice their opinions in the workplace. So expectations of new graduates at the end of their first year in the workforce for their level of clinical expertise. I'm just going to move that over. So the highest amount of midwives reported being able to perform neonatal or newborn resuscitation. The second highest was being able to make decisions about when to refer for obstetric consultation. The next highest was being able to perform an amniotomy, so breaking the woman's waters when she's in labour. The next one was being able to attach a fetal scalp electrode, so that's putting a little electrode on the baby's head for internal monitoring. The next one was being able to perform cannulation, and the last one was being able to perform perineal infiltration repair, so being able to repair the woman's perineum post-birth. So we also asked this, and only 41% of midwives said that their service fosters a culture that facilitates evidence-based midwifery practice. We also asked the reasons why midwives thought that new midwifery graduates leave the profession. So as you can see here, the highest one was stress and pressure of clinical environment. The next one was workplace culture. The next one was disillusionment with challenges to be working in alignment with professional philosophy. The next one was lack of support in graduate transition, and the last one was lack of psychological safety. So now I'm just going to present some quotes that the midwives actually wrote about why they thought new graduates leave the profession. So bullying and being left to sink or swim, difficulty with shift work and family life, perceived lack of competence by other staff. These new grads are not supported to enhance their skills. They are bullied until they leave. Fear of an unsafe birth and blame for poor outcome. Unmanageable workload acuity and not being supported. Pay rates not being aligned with other workload or other professions or trades. Educational support is offered, and I believe managers in my workplace are as supportive as possible. However, a junior workforce and staff shortages mean that some graduates with greater needs may suffer. Graduates who are deemed to be thriving may sometimes not receive as much support as they need due to perception that they are okay. Other reasons why they leave. I feel as students they are not always encouraged to undertake all necessary practical assessments regularly, for example, vaginal examinations or catheterisation, and as thus lacking confidence during their graduate year. Most feel highly pressured, especially in high-risk areas, as they've not had confidence instilled into them through frequent practice even by their third year. Lack of ongoing mandatory best practice education amongst experienced midwives, lack of support from all levels of management, including government, fragmented models of care between health services, adherence and encouragement of a medical model, lack of management that encourage midwifery models of care. In our hospital bachelor degree, there is a major emphasis on continuity of care. However, most graduates end up in a tertiary level hospital full of high-risk women pregnancies and are therefore unprepared for the level of stress and risk. They need to spend more time on the wards and less time in continuity. Unrealistic expectations about what work life is like, not work ready, not ready for shift work, or truly being on call and having other work to do as well. As a student focusing on one woman, as a midwife, you have several to provide equal attention. Their ability to be autonomous midwives is hampered by the hospital system, framed predominantly by nursing subservience and lack of professional respect for midwife autonomy by medical staff. University not preparing them for appropriate practice. Student nurses are prepared for what they face in a nursing new graduate program. Student midwives are not lacking prioritising and time management skills when entering a hospital-based system. Seeing violence against women in the birthing setting. We also asked them how they provided support for new midwifery graduates. Open, non-judgmental dialogue, encouraging graduates to have time together to share concerns in a group, by acknowledging it can be a tough time and being supportive. If something has gone wrong, talking it through, but having them tell me what went right, helping to to give orientation, give tips and asking questions. As an undergrad support midwife, I advocate for graduates not to be paired with the student as much as possible, providing regular structured reflective clinical supervision sessions, finding out their goals and aspirations. I am a new grad myself, so I provide peer support, being kind, supportive, honest and available, asking them to explain what their findings are first or what they think could be happening in a given situation, as well as asking them what it is that they would like me to do to assist, encouraging them to continue to question, supporting them to ensure best midwifery practice. As a team leader, often on weekends or night shift when there is no education midwife, I find my workload drastically increases as I need to support new grads. Chatting throughout the shift, shared experiences, acknowledging a hard shift and thanking them, telling them when they've done a great job, sharing with others their positive contributions, support but not take over, and be approachable. Providing additional support and education about psychosocial concerns that they may not have faced, like domestic violence, mental illness and substance abuse, child protection, in a trauma-informed, culturally safe manner. Providing the bridge between uni and reality, providing information regarding alternative opportunities, where to get support externally, and promoting further study and research. We also ask them how they think they can make graduates feel part of a team. So spending time with them to make sure they know where things are and how they're going, prioritising them, enhancing their skills by giving them a wide variety of clinical experiences where possible, inclusivity with social things, listening to their opinion, discussing what's important to them, making them feel valued and part of the team, letting them give us feedback as teachers and mentors, including them in coffee runs, smiling, welcoming, valuing them but don't overwhelm them with a clinical load, to refer to them as graduates, to not refer to them as graduates, rather as midwives, engage them as an integral part of the care team whose opinion is valued and important, treating them with respect and open communication by checking in with them regularly, making myself available to them even when we're busy or understaffed, and reminding them that we're all in their shoes once, knowing their name, providing an opportunity to debrief and reflect when required, involving them, inviting them to participate in meetings and projects, acknowledging their good work, acknowledging situations where you as an older midwife could have done better, listening to their questions and concerns, suggestions they have, appropriate workload for the level of experience, and supporting them when they encounter conditions that change that workload or emergencies. Workplace culture is based on sometimes invisible hierarchies and some strong personalities who are unwilling to support new grads. A culture is sink or swim, and throwing new grads in the deep end persists despite numerous attempts to change the culture. Poor behaviour towards new grads is not called up, addressed and blamed on acuity and huge workloads.
Virginia, maybe just one more minute.
Okay, no worries, that's fine. And the last slide, how do you think relationships are built with new midwifery graduates? Helping them during the shifts, treating them people like you want to be treated by fostering mutual respect and acknowledging individual life experiences, providing a safe place to ask questions by respecting them as practitioners and getting to know their goals and ambitions. Saying you'll be there for them is useless unless you're actually there. They need to be able to talk to me at 2 a.m. with problems or ring on a Saturday with questions. Treating them as educated people and equal members of the work team. I work in the exact model the BMids are trained in and love seeing them work alongside me in their final year, then see how rewarding it is when they can return to this model of care as a new graduate. With care, kindness, support, having their back and understanding positivity and encouragement. And that's it. Thank you for listening.
Oh, fabulous presentation, Virginia. What an interesting study, and what a sad study in lots of ways too.
Yeah.
It's like Groundhog Day, isn't it really?
Yeah.
So we'll hold questions to the end because I'm sure with both those wonderful presentations, there may be some questions. We now have a joint presentation from Dr. Fiona McDermott and Dr. Kate O'Reilly. And they're presenting today on shining a light on Australian women's knowledge and experience of perimenopause and menopause. So welcome, Kate and Fiona, and thank you very much.
Thanks, Anna. Thanks everyone for coming today. Everyone can see my slideshow okay? Yep. Okay, so this project really came about when a friend of mine came to me and was having horrific time with menopause and was talking about how she wouldn't even go to her GP for a pap smear because of the vaginal dryness she was experiencing. It was incredibly painful. And as a nurse and a midwife and a woman, I was actually horrified at how little I actually knew about menopause, and it had never been part of my education or training all the way through my nursing. And then the more people we talk to, the more we realise that a lot of women don't have the knowledge about menopause. So we came up with this project. It was a mixed method study, and we did a survey. And I'll just briefly, we're just pulling out a few things because there was just so much information that we got. And we did some interviews. And from the moment we released the survey, we were just inundated. We ended up having to shut it off at like 480 women. So obviously women were needing to have a voice and wanted to share their experiences of menopause. So we had 480 in the survey, and then we interviewed 25 in face-to-face interviews. The mean age was 51.69 years, which is consistent with the literature. And we did ask them their education level because we wanted to see if there was a correlation between their education and their knowledge. What we did find, just briefly going through some of the findings. Sorry, I already did that. So we analysed it using SPSS and Braun and Clark for the qualitative data. What we did find is women really did have limited knowledge, and what they expected to happen in menopause, it was a lot worse than what they thought. They really thought it was going to be a few hot flushes, maybe some weight gain, and their periods would stop. And interesting, the definition of menopause itself is like not having a period for a year. So even that definition was often misleading for women. They didn't expect it to be so horrific, you know, the irregular bleeding, the weight gain, the brain fog, fatigue, mood swings. Interesting, they were quite aware that of comorbidities of menopause. So they knew that it was a contributing factor to osteoporosis, and 96% of them knew that. What they didn't know was about all the other risks, such as cardiovascular risks. So we assumed that because of the marketing and media focus on osteoporosis in older women, they were more aware of that. The limited knowledge they had and their experiences had a significant impact on their lives. There was one participant who was working in a corporate job and was responsible for a big team of employees, and she just couldn't work anymore. And she felt depressed, she felt worthless, and she just couldn't deal with life. They experienced feelings of shame and not being normal. And one lady was talking about how she didn't even want to go to her son's wedding because the severity of her hot flushes, she'd go bright red and she'd be sweating, and she just became really apathetic about life. Also, for some women, there was a real taboo around menopause, and this was cultural, and really it's just not something that's getting talked about. And they felt that it was just part of being a woman, just part of getting older, but they felt old because of it. And the limited knowledge, it wasn't through want of trying. These women were desperately trying to get information about menopause, and a lot of them went to their GPs and just felt dismissed. They were often said, oh yeah, you're probably in menopause, and that was it, and they were just sort of sent on their merry way. Or they felt pressured into taking HRT or antidepressants. A lot of the women were offered antidepressants right off the bat without sort of any information about what it would do for them, that it would help them with the symptoms. And there was still quite a bit of misinformation out there about HRT and this association with cancer and breast cancer. One participant was told she just needed to lose weight and she'd be fine. They did have better luck going to women's health clinics, but there was still that lack of information out there. They did find that they had to go and find the information themselves. So they jumped on Google and they listened to podcasts, and they went to media, different social groups. They did get a lot of information, but there was also a lot of misinformation out there, and they ended up going down this sort of information rabbit hole where there was a lot of conflicting information particularly around HRT, take it, don't take it, does this, does that. So there was a lack of evidence-based information really out there. But it did give them a sense of empowerment and confidence to kind of go back to their GP and make demands about their health and say what they wanted. There was one poor lady that she'd been to her GP several times because of her irregular bleeding, and she was just told, it's just menopause, it's just, wait and see. And it didn't sit well with her. So she ended up asking for a specialist to refer on. They found precancerous cells and she ended up with a hysterectomy. So this lack of information and the lack of knowledge that GPs have about menopause is really quite concerning, considering the comorbidities of menopause and what can occur. The majority of women actually got most information from their friends, their family, work colleagues, and we feel that it's becoming more and more talked about. They feel it's therapeutic talking to other women, and they feel a more positive attitude, which we know can help women through the transition. So ultimately what we found is, menopause is poorly defined. Education level had no correlation with their knowledge. So the majority of our participants had quite high education, above secondary school. So masters, PhDs, and we had some women that had limited, didn't really go past secondary school, but it was irrelevant in what they knew about menopause. There's a lack of adequate information, lack of support from health professionals, including especially GPs, more luck with women's health clinics. Health implications are so significant, and women are just struggling so hard going through this stage, and they're just not talking about it, and it's just they're not being helped. And we know that there's more women in the workplace than with menopause than out of the workplace. And it's almost like a double jeopardy where, their gender and their age kind of intersect, and they're so disadvantaged and they're so vulnerable at this stage. And if we are serious about, empowering women and achieving gender equality as part of the Sustainable Development Goals, then we need to have this discussion around menstrual health, including menopause. And Kate is going to present on the mental health implications of these women.
Thanks,
Kate.
Welcome, Kate.
Okay, everyone, can you see my slides?
We can, thank you.
Thank you. So as Fiona mentioned, it was a mixed method study. So today, I'm just focusing on sharing quantitative and qualitative data specific to women's mental health. So the information is summarised, but more detail is included in a paper that we've currently got under review. So hopefully we can share that with you soon. So firstly, here's a little bit of background to set the mood. So stigmatisation and taboos associated with women's menstrual cycles are steeped in this ancient religious belief that menstrual blood is unclean and any contact with a woman during this time could cause impurity. Many modern depictions of menstruating women are that they're irrational, angry and aggressive, all of which have prejudicial socialised expectations that the woman should be in this constant control of her emotions. Crisler and Gorman highlight that many cultures have patriarchal structures which reinforce the negativity and silencing of anything to do with the uterus. And this is due to this misplaced belief that the uterus was responsible for hysteria in women. Evans explains that the Greek word for uterus is hystera, and so that's the origin for what was labelled hysteria, a medical condition that was attributed to the female sex. So additionally, mental health conditions have been long associated with stigmatisation and marginalisation, which is a barrier to individuals seeking treatment. Stigma related to both the menstrual cycle and menstrual health, in addition to inequity for women and girls in accessing sexual and reproductive health services, perpetuates what we've identified in a literature review that we've got published in Journal of Clinical Nursing, is this unspoken message that women should suffer through perimenopause and menopause in silence. So now that you've got some of this historical background, which even today continues to influence discussions of women's menstruation or lack of, let me share some findings with you. So we integrated quantitative and qualitative data specific to women's mental health into 3 themes. And so these are increased anxiety and depression, a negative impact on emotions, and a negative impact on self-worth. So qualitative findings from the study highlighted that many women who were perimenopausal or in menopause experienced changes in their psychological well-being. They reported increased anxiety or depression, which coincided with this fluctuation in hormones that they experienced during this phase of their lives. So I've included a couple of quotes there for you. More than 3/4 of respondents in the survey agreed that there was an increased risk of depression, so that gave us some understanding of their knowledge. The Women's Health Questionnaire component that we included in our survey asked women in different ways if they had feelings of anxiety, and a large proportion of women who responded did report definitely or sometimes being frightened or panicked for no reason. When women were asked if they experienced palpitations or had feelings of butterflies, which can be a sign of anxiety, there was a similar response, with just under half of the women reporting definitely or sometimes having those feelings. More than 2/3 of the women reported definitely or sometimes feeling tense and wound up. 53% of the women reported difficulty getting off to sleep, and that can also be associated with anxiety. And then we asked women if they woke early and slept badly for the rest of the night. 26% of respondents said that yes, this was what they experienced. And then 41% of women said that this was the case for them sometimes. Women were asked if they felt more tired, and 43% of the respondents identified yes, that definitely they felt more tired in this phase of their lives. Many women in this study reported that perimenopause and/or menopause had this negative impact on their emotions, and participants highlighted that it made them feel disconnected to the person that they originally identified as, because they found it difficult to regulate emotions that they were experiencing. In the quantitative survey, women were asked if they felt miserable or sad, and overall of the 412 respondents to that question, 45% identified that yes, sometimes they felt miserable and sad, and that aligns with the emotional ability that women spoke about in interviews. Some women who participated in interviews reported feeling less confident and less valuable, which impacted on their overall feelings of well-being. And so Claire talked about feeling as though she needed to hide away. Overall, generally, women had a positive sense of well-being, but there were 74 women reporting low or no feelings of well-being. And the feeling of worthlessness that participants identified in interviews was definitely correlated with what we found in the survey. So while most participants reported having a general positive wellbeing, over half of the women who completed the survey reported that they'd actually lost interest in things. Another finding that we were really alarmed to see was that 25 women indicated that life wasn't worth living. And that's in addition, so that's additionally 62 women reported that sometimes they felt life wasn't worth living. So we're pretty alarmed by those figures. So the findings from this research are clinically important because they raise awareness of the impacts of perimenopause and menopause and show us how far-reaching this is for them. Timely and relevant assessment is critical to ensuring women's health and wellbeing. So although there's this increasing discourse, and Fiona mentioned that, around the topic of perimenopause and menopause, the way in which it's discussed includes comedy, euphemism, and these whispered, hushed tones, and that actually perpetuates a not so subtle message that the topic remains secret women's business. and that women's ageing bodies are failing them, implying that they're less valuable. So the use of comedy has definitely aided in bringing the discussion of menopause into the public domain. And I don't know how many of you have seen Menopause the musical. And in some sense, this does lift the veil of secrecy. However, the danger is that in using humour to discuss perimenopause and menopause, women's experiences are trivialised and not given the full attention that they deserved, not just by clinicians, but by us as well. So we do oppose this pejorative link that, between menopause and mental health, and we really caution against this linear link being made between the two. However, it is critical that clinicians identify that fluctuating hormones may be one of a variety of factors which must be considered in the comprehensive physical and mental health assessment of women who may be in this phase of their lives. Suitable and timely interventions need to be available to all women to better support women's quality of life. Women in this study shone a light on the fact that stigma and shame associated with perimenopause, menopause, and a deterioration in mental well-being continues to be perpetuated within society. The results from this study highlight an unmet need for women and can help to inform the design and provision of holistic services, which include the need to consider the impact of perimenopause and menopause on women's mental health. Thanks, everyone.
Oh, wow. Thank you, Kate. What an interesting study that is. We're going to open up now to the group for any questions or statements. So just recapping, because we've had 3 fantastic presentations today. Loretta talking about safe forward strategies. Virginia talking about midwives' perceptions support in new grad programs. And you've just heard from Kate and Fiona talking about perimenopause and menopause. So I'll open it up to everyone. Just want to thank those 3 presenters for just wonderful presentations and really important, interesting studies.
Can I ask more a comment to Kate and to Fiona? I see so many parallels between the whole perimenopause, menopause discourse, silence, hidden nature, misunderstanding, and poor treatment with the whole issues with the issue of miscarriage, which is something so many women share. And it's not until you have a miscarriage and you share it with someone and then they tell you, oh, I had one too. There's this sort of real secret society of women's pain that needs to get out because women are left so isolated and alone, thinking something's so wrong with them. So just a comment really to say thank you for raising that. I thought I was going completely mad. And I was educated, so I just can't imagine. And I, you know, my experience was relatively sedate, really, compared to many women. So I just wanted to say thank you, and let's get these topics out there so they're not so secretive.
Yeah, and look, a lot of our participants thought they were going crazy. They literally thought they were going crazy. They thought there was something wrong with them. They were not normal. They were having a breakdown. And it wasn't until they started desperately trying to get information that they realized, okay, this might be menopause. And they didn't expect it to be quite as severe as what it was. And, you know, that was a limitation of our study as well, as we probably only heard from women that had negative experiences. We didn't get much from women that, you know, had a great experience, and we don't know about those women. But yeah, they were going crazy.
And I think just to add to Fiona too, it's like we understand that at this time in women's lives, there's a lot going on. So it's this constellation of factors. It's not just menopause. It's, you know, caring for children, caring for aging parents, work issues that Fiona's talked about. So it's not just that, but that in combination with everything else, it just makes it such a difficult time for so many women. And yeah, they were desperate to tell their stories.
Fiona, I'll come to you in a second, just in the interest of time, everybody. I'm sorry, Fiona. Virginia has a question for Loretta in the chat.
Oh, great, thanks. Yeah, Loretta, I was just wondering about the translational aspect of the work. Are other wards, just even at Nepean, now keen to engage and look at their own strategies and approach related to the initiatives?
Yeah, that's a great question. The nurse executive have given me a nurse working in a clinical nurse consultant role so that we can actually implement that in other wards. And we've literally just started that in the last fortnight, and we've now got 3 more wards really interested in doing it with us. So yeah, we're really hoping to, I've got grand plans to have that in most wards in Nepean, because I think it's just worked so well.
Great, excellent.
Fantastic.
Yeah, really good.
Diana.
Yeah, I was just going to say to Loretta, and I also was going to say something to Kate and Fiona, if that's all right. But Loretta, it was really interesting because when we did the hotel quarantine work, one of the things we found out about what was happening in hotel quarantine is they had a 2-step debrief process. And they seemed to really like that, where the first one was just a vent, what happened. And the next one would be a full-on debrief using the Gibbs cycle a week later. And they actually talked about what a great way that was doing. I just thought I'd bring that up.
Mm.
But I was going to say to Kate and Fiona, as a mental health nurse, it worries me when people start talking about, you know, mental health aspects. I just sit there and I think this is dragging women into antidepressants, you know, medication, medical models, stigmatisation, and generally down the mental health route. And a lot of things happen around menopause. It's not just the physical aspect, it's also the fact that children are probably leaving home, you know, marriages break down, all kinds of things happen. And I'm just wondering if, you know, we talk about mental well-being or something like that, just to get rid of the stigma and like to stop, you know, everyone thinking, oh, well, we'll just give them antidepressants and they'll feel better then. That's just, I don't know what you think about that idea.
Yeah, definitely. It's it's about shifting the language, isn't it? In lots of areas. Yeah.
Yeah.
And Diana, you're right. You know, our health professionals need to be better educated and not to be just pushing, you know, antidepressants and, you know, HRT.
CBT.
Yeah, but as a nurse, it's never been part of my education and looking after patients. So it needs to be there, needs to be part of the conversation.
Yeah, anyway, just a comment.
I know we're out of time. I'd just like to ask Virginia, because she's yet to have a question.
Oh, look, it really was. I was actually.
No, sorry, Virginia Schmid, Virginia Stultz.
Oh, yes, it's okay. Yeah.
Virginia, I just wanted to ask about the bullying. And so much of that goes on in general nursing as well. Does your study add some highlights about how this can finally be addressed? Because it is a bit like Groundhog Day, isn't it? The nurses eating their young. So
Yeah, so that they were in the textual comments mainly. I know a lot of the comments were negative, but we do have some really positive comments as well. And I haven't yet really got to analyse all the other questions. So that will be one of my priorities this year, to get that study analysed with my team, my large team, and so and write a publication. Yeah.
Okay, thank you. Well, that concludes our session today. What 3 fabulous presentations. I'd like to thank our 4 speakers very, very much, and thank you all for attending.